Jeff, go ahead.
So I do *6 first?
We can hear you now, Jeff.
Good. Well, thank you all for joining us today and taking time out of your busy schedules. I'm Jeff Tagg, Chair of the Addiction and Mental Health Provincial Advisory Committee. We're piloting this new virtual series to provide more in-depth information on key subjects that many of you have highlighted as top priorities for you and your stakeholders. We're pleased that many people have joined in for today's session on addiction and mental health. We have members of our health advisory councils from across Alberta, representatives from AHS Patient and Family Group, as well as representatives from Alberta's foundations. There's considerable progress being made across many AHS portfolios, and we encourage you to share what you learn about today about addiction and mental health with your communities and stakeholders. Thanks for the questions that were submitted in advance, and if you have further questions, you can submit them after the session by emailing community.engagement@ahs.ca. Just a couple of reminders before I introduce our presenters. This is a pilot and we're trying out the Link web app. If you face any technology-related concerns at any time, you can dial into the conference line provided, and the toll-free number is 877-352-4495, and this conference ID 3551484, followed by the pound sign. And follow along with the presentation as you were directed in advance. And with that, I'm very happy to introduce our presenters. Dr. Nick Mitchell is the Senior Medical Director of the Addiction and Mental Health Strategic Clinical Network and Provincial Medical Director for the Addiction and Mental Health Provincial Team. He's also an Assistant Professor in the Department of Psychiatry at the University of Alberta and maintains an active clinical practice with the Consultation Liaison Psychiatry Service at the U of A Hospital. And second, Vary Andres is the Executive Director for Addiction and Mental Health with Alberta Health Services, and he leads the coordination of addiction and mental health treatment and prevention services. This includes supporting operational services through the development of policy and standards, care quality improvement, professional development, and service reporting. And more importantly than those introductions, they are both very invaluable resources to the council of which I am a member. So just a reminder to our presenters, some participants today are following along with PDF, so if you could please refer to the page number, it would be appreciated. And now I'm pleased to hand over to Dr. Mitchell.
And Nick, if you can go ahead and just take over as presenter. Thank you.
Thanks. All right. Thank you, Jeff. So as Jeff mentioned, I have the privilege of being both the Senior Medical Director of the Addictions Mental Health Strategic Clinical Network, as well as the Provincial Medical Director for the Addictions Mental Health Provincial Team. So I've been able to interact with our Provincial Advisory Council over the last almost 3 years now. And it's something where I think we see the incredible value of having a provincial advisory council where we have broad representation from across the province, people with lived experience, family members who have struggled with addictions and mental health concerns. And I appreciate the service of all the PAC members and all the HAC members who are joining us today, and thank you for taking your time out. I'm just going to start on slide number 2 with a bit of our agenda. We're going to give you a brief overview of the addiction mental health portfolio, talk about a few of the issues and concerns that have been raised, that we've heard have been raised through the advisory councils and through patient and family advisors, discuss some of the current trends and initiatives that are going on in the addictions and mental health portfolio across the province, and then discuss about how we can work together. It's a lot to cover in a short period of time, so let's see. Yeah, there we go. I got it to advance. Did it work, Sheila?
Yeah, thank you, Jeff.
That's Nick. Is
Sorry,
it
Nick.
advancing
Sorry,
for
Nick.
me?
Thank you. Yep,
Okay,
go
good.
ahead.
So when we look at our portfolio, addictions, mental health, and AHS, is divided amongst the 5 operational zones. So each zone has an addictions mental health arm. As well, we have the provincial team, which deals largely in policy, strategy, government relations, and the strategic clinical network, which was formed about 6 years ago and is involved in health service innovation, research, and translation to practice. All 3 arms of the addictions mental health portfolio, whether that be operations, the provincial team, or the SCN, try to engage with community members, including through the Provincial Advisory Council, but also with some of our nonprofit and non-governmental. So we're part of the healthcare ecosystem, but by no means are we the entirety of it. We know in Alberta there is a large and growing demand for addiction mental health services. Many of you will be familiar with these numbers, but we see a large number, over 800,000 Albertans seeking addiction mental health care and primary care. We have addiction mental health services through AHS across the province, which includes both inpatient and outpatient beds. We also have outpatient addictions programs, such as residential detox programs. One of the main pinch points and initial points of contact for many of our clients is through the emergency departments. And so there's been a lot of work ongoing to see how we can better develop and integrate services for individuals when they're in crisis through the emergency departments. There are a number of drivers for strategy and innovation in addictions and mental health in Alberta. Many of you will be aware of the Value Mental Health Report, and we had the opportunity to participate in consultations that led up to that report. There were 32 recommendations with a number of actions underneath each of those recommendations that came out of the report. We're still awaiting for Cabinet to accept the final report to give us an idea of what direction they would like us to take moving forward, but there are 4 populations that have been identified as requiring attention, that being children and youth and families, people with complex and multiple mental health needs, people requiring addiction services, and Indigenous communities. As well, we receive direction from the Office of the Auditor General. Within AHS, there's an initiative that is a joint initiative with monies from the provincial and federal government looking at enhancing community care, which is another way of saying how do we try to upstream our resources and our interventions for individuals to try to catch them before their illness is so severe that they require hospitalization, and how do we do this in a way where we can keep them as close as possible to home. And then long-range planning, which really has to do with looking at strategically where are we at currently in terms of our resourcing and how things are distributed across the province, and how do we change that over time to match with changing demographics and a growing population. So the things that we want to specifically address, which were raised as concerns and issues amongst the Health Advisory Council members and the Provincial Advisory Council members, are things around access and wait times. So we'll talk a little bit about that. Some of the programs we have to support addiction and mental health services in rural and remote areas, community treatment orders, and stigma. And then I'm going to pass it over to Barry Andrews to talk a bit about some specific populations, as well as some of our other work around prevention and promotion and harm reduction. So in terms of wait times, this is a sort of a perennial concern for Albertans, is how long it takes to get in to see an individual for service. And we know that the earlier we intervene for many of our patients and their families, the better the outcomes we get are. So through a number of initiatives, we're attempting to impact this. So many of you would have heard in the news about Rutherford House and the enhanced mental health capacity for children and youth in Edmonton zone that's recently opened up, and we're already seeing an impact on our wait times in emergency because of that. There is an access and transition grant from the government that is supporting a number of projects like Access Mental Health in Calgary Zone. So the Calgary Zone took it upon themselves to centralize all their addictions and mental health intake processes to make a single point of contact, which seems to be working very well for them. And Edmonton Zone is following suit. And we want to see that expand to other zones, the rural zones. There's been quite a bit of work in the strategic clinical network side with our operational colleagues in trying to increase navigation supports. So this would be things like embedding peer support workers. Edmonton Zone has had some success in embedding peer support workers in a number of their programs. And we're looking at how we can do that in more creative ways, such as in the emergency departments, for when individuals come in that might not require acute admission to an addictions mental health inpatient unit, to help them to navigate the transition to community services or figure out where to seek support in the community. There's been some work with EMS and community paramedics around trying to offer support at the first point of intervention. So even before you get to the hospital, can EMS or paramedics provide support? So there's a number of things that are ongoing to try to reduce wait times for individuals that are seeking care, or bring that care closer to their initial point of contact, so people don't get triaged and end up on a wait list waiting to access service. Because of the nature of our province, there's often a disparity in terms of access between our urban centers and our rural and remote centers. And a lot of our work and our initiatives here have to do with partnering with communities around identifying what their needs are and what resources already exist, how we can work with those resources and collaborate with them to improve access for patients and families. So one of my favorite examples is what Bonnyville's been doing. So the Bonnyville Children and Adolescent Mental Health Collaborative, AHS is a partner in that, and there are a number of other community partners. They have changed the way that in that community, children and adolescents and their families are able to access mental health supports. So it's a great example of a community level collaboration to address a specific need. As well, we have traveling clinics that go to a number of First Nations communities. We've recently had expansion of our opioid response. So we have opiate detoxification and treatment clinics, the most recent of which is opened in Grand Prairie. And one of my favorite projects is telemental health. So particularly when we get into the very remote parts of our province, I'm thinking of the far north of our province, or for specialized services, child and adolescent mental health, for example, where there may not be specialists in many of the communities. Our telemental health program services upwards of 9,000 people a year. And in fact, is seeing a year-over-year increase. Last year, we saw a 15% increase in service volumes there. So that's something that I think we want to continue to develop, to provide access, particularly to specialized services in areas where traditionally we haven't been able to reach people. One of the questions that was raised was around community treatment orders and how those are being managed. For those of you that are less aware, community treatment order is a form under the Mental Health Act that allows us to monitor an individual in the community and provide mental health treatment to them. And if they are not participating in that mental health treatment, to assess them. So the idea is to get ahead of the game for folks and keep them engaged in treatment before they fall off the map, end up getting sick and requiring rehospitalization. So this is primarily focused at individuals with severe and persistent mental illness, things like bipolar disorder and schizophrenia. We have, since the community treatment orders were initiated in the province, had almost 1,300 clients who have been issued a community treatment order. And what we found is, if you'll note, this is on slide 9, the difference between the pre and post CTO initiation. The individuals who are receiving these community treatment orders are actually able to stay at a hospital. We see a significant reduction in the number of those individuals who are hospitalized and the number of times they present to hospital. So this has been something that's been very helpful as a tool for us to try to keep people engaged with treatment. CTOs, when they're put in place, are in effect for 6 months, and they have to be renewed every 6 months and reviewed on an ongoing basis. So it's not a license for us to keep people in treatment on an ongoing basis, but it's something where an individual can consent to being on a CTO, and it allows us to keep them engaged with treatment more actively. Slide 10 references stigma, and this is an area that continues to be a huge concern within the healthcare system and within society more broadly. It's something that's very much embedded in what we do and how we work. So even changing the language we use, we try to use recovery-based language as opposed to discussing addictions or substance use. Because it changes people's attitudes towards, and this is healthcare professionals' attitudes towards the clients they serve. So we're doing training for our staff internally in Alberta Health Services. That's things like Road to Mental Readiness and Trauma-Informed Care, to increase the capacity of our staff to deal with individuals with addictions and mental health concerns in a less stigmatizing way, a more open way that invites people into treatment and doesn't add another barrier. In addition, there's the mental health first aid course, which many of you might have heard of, that's been used to try to increase our capacity to respond to crises, such as the fire in Fort McMurray. It's delivered by the Mental Health Commission of Canada, and we're a partner in that. And then there's other more unique sorts of projects out there. A really interesting one that toured Alberta recently is the Theatre for Living, which is a participatory theatre program where there's I believe the individual who developed it's out of BC, where the participants, the audience members, actually participate in crafting a narrative around a mental health presentation or interaction in the healthcare system, and identify where there are barriers or challenges or stigma expressed and how things could be done differently. And this, if any of you had a chance to see it when it came through, I believe it was last year, it was remarkable. So as I say, I'll pass it over now to Barry Andrews, who will discuss supports for various populations. Barry?
Terrific. Thank you very much, Nick, and thanks again to everybody for joining. It's terrific to see the interest in addiction and mental health, as we know just the importance of this area. We started talking a little bit about the areas of questions that we received. So on slide 11, you'll see the identification of some various other populations that we want to focus on just a little bit in terms of highlighting some of the activities that are going in those underway in those areas relative to children, youth, and families, seniors, Indigenous populations, and then other populations who may have some specific vulnerabilities. So on slide 12, starting with children, youth, and families, we talked a little bit already about the multiple services that are available across the province, and these services certainly are across the continuum, from early intervention, screening, to indeed prevention, to more focused, more specialized and acute services, including intensive treatment and hospitalized treatment as well. We certainly, I think, are recognizing that access for children and youth is a real priority, and doing a number of things wanting to address how that can be addressed. We talked about already the Rutherford Clinic and how that's having an impact as well. Telehealth being another vehicle, but we also know that there's opportunities around increasing the competency capacity of providers, both within Alberta Health Services and beyond, to be able to respond at the right level to those children and youth who have needs. So to that end, doing work with the mental health literacy, which is working on building wellness in youth and teaching those kind of wellness skills in partnership with the education system. Certainly, Healthy Mind, Healthy Children is a service that provides that consultation to primary care physicians and to educators to again increase their competency and services. There's a number of very specialized programs. You may be familiar or heard about the Protection of Children Abusing Drugs service, and under this initiative, parents and guardians who have children who are abusing drugs can seek a court order to have the child confined to a protective safe house for a relatively short period of detoxification, stabilization, assessment, and then linkage to further treatment under which they can continue to receive the supports that they need. Also, a lot of work in partnership with other providers, with the school boards and school educational system around the regional collaborative service delivery models, in which AHS is working to provide services embedded right in the school systems, right in the classrooms for children and youth, and supports to teachers in that way as well. Excuse me, as well with the mental health capacity building in schools initiative. And in this initiative, there's, I think, in the range of just under 40 schools in which staff work with children, youth, their families, and the teachers to provide increased screening, intervention, and build those wellness skills around mental health for the youth. We're working recognizing that access is always a challenge, particularly for children and youth, and so working with the government on an initiative last year around the Help for Me web portal. And under this, it'll be a range of youth-centered addiction, mental health information and resources, focusing on topics such as mood and anxiety, stress, depression, alcohol, and other drugs, and self-harm, including suicide. So it'll provide awareness and provide resources and referral information. Moving on to slide 13, relative to seniors, we recognize that isolation can be a significant factor for seniors, and again, providing a range of services to help address that, from specialized day programs to further consultations, crisis counseling, supports to caregivers, and all those type of things that provide that additional support. There's some real interesting specific initiatives underway in working with primary care in Calgary, relative to working with the primary care network there, and identifying and looking at how we can augment services across AHS as a link to primary care and within the primary care network to further provide supports to seniors and frail elderly. Slide 14, we're focusing a little bit on the services available for Indigenous populations. I think we're certainly recognizing that there's unique needs amongst this group, and we've got a whole Indigenous health program that provides a range of services that are culturally sensitive. They support a holistic approach that integrates the mind, body, spirit, and emotions, and again, that ideally that full range of services, including assessment, referral, a lot of work in outreach, cultural awareness, and working with communities to develop competencies and the supports that are unique in each community. And that's a bit of what's behind the Honoring Life program as well. While this one focuses on specific skills around suicide prevention, it's really about supporting communities to build that capacity and contribute to well-being and resiliency amongst the community, and particularly with Indigenous youth. So it involves a lot of consultation, a lot of work at the community level. One of the things that was done, which is very interesting to inform this work and help advise on it, was the work around patient journeys. So several interviews were held in communities across the province with multiple groups, but one of them being Indigenous focus groups, or to better understand the overall needs and where services could be better. And it was really interesting because not surprisingly, there were a lot of findings and themes around access to services, and access to services closer to home, on reserve, for example. But also, what was identified in that was the need for specific housing and specialized housing for patients which have unique needs. and also the linkage to primary care and access to addiction mental health services and primary care certainly came out through those patient journeys. So it's a very interesting discovery, if you like, in terms of what the needs are and how services could better respond to it. We mentioned access to services as an ongoing need, and so slide 15, we're talking a little bit about the navigation supports, and we certainly hear from often from Albertans that it's difficult to find out about services or to transition from one to another, and that's really becoming and is a primary goal that we have in front of us in terms of that transition of services and access to services across the whole continuum. And to that end, we're looking at and have done some work on our website to make it more navigable, easier to find information at a community and local level. And as Dr. Mitchell already mentioned, working on centralized intake as well, and intake processes where there's a one point of access that's readily accessible, immediately accessible, and can link them to the needed services quite specifically. So people don't have to go hunting on their own, and provide that kind of supports to it. Already in place in Calgary, as you mentioned, and work underway in Edmonton and will be elsewhere. Of course, HealthLink, the 811 numbers are there, and certainly serve as primary points of contact for finding out information about services. We were also asked to speak a little bit to some of the trends that we're seeing in terms of a couple key areas of concern, that being suicide, and certainly we've seen a lot, and you're aware a lot of the opioid crisis that is occurring in Alberta and indeed primarily across Western Canada. Slide 17, just want to talk a little bit about suicide and some of the trends there. Apologize that the graphic on the right, it might be a little small, but you can see in this graphic data from Alberta data from 2012 to 2016, and the green bar on the top is the combined male and female suicide rate for the province. And you can see for the first 3 years from 12, pretty flat, and then an increase in 15, and a further subsequent decrease following that in 16. And we don't have further numbers beyond that at this point. So there's certainly a good number of initiatives underway to try and to build supports for suicide prevention. Part of that is internally, and part of it is more at a population level. One of the things we're recognizing is that amongst, first of all, primarily addiction mental health staff, but secondly, all staff throughout AHS need to have a certain level of awareness, competency for being able to identify risks and take the appropriate action when an individual, regardless what setting, presents some of the indicators that there could be risk of harm. And to that end, there's a couple training services that are available, the Applied Suicide Intervention Skill Training Program, and last year we just launched the Suicide Prevention Risk Assessment Management training program for addiction and mental health staff, and to date over 500 have taken that training, and we're rolling that out to non-age addiction and mental health staff as well. Other initiatives focusing on prevention and promotion, the Community Helpers Program, I mentioned the mental health capacity building. So these are all services that try and build that resiliency and strength at an individual and community level, getting at some of the root cause issues relative to risk of harm. Secondly, in terms of the opioid response, probably not telling anything you're not aware of relative to the rates of overdose that we're seeing in the province. They were continuing to increase. Last year there was 349. So of course that is of significant concern, and significant action being taken in response to that. It really does call on a comprehensive response and a comprehensive approach. not just about treatment, but that's a key element, a key component of it. It's also about public awareness, and we've undertaken last year some public awareness campaigns in the current design phase for the next public awareness campaign. It does involve that expansion of treatment, and also at the last resort, if you like, distribution of naloxone, which can, in the short term, reverse the effects of an opioid overdose long enough for medical aid to be provided. So on the expanding treatment side of things, we've certainly moving ahead with a grant from Health, and services have opened in Cardston earlier through a telehealth, a rural model in central Alberta in Wetaskiwin, Rocky, and Stettler and Ponoka. So really excited about that model and want to look at how that model will be able to serve other areas, particularly those that are not urban centers. And then certainly opening further clinics in urban centers, including most recently in this month in Grand Prairie. We're also recognizing that primary care is a primary point of contact, and working on building that services within primary care for those who access services in that way. Mentioned naloxone. As you know, naloxone is a drug that when administered, temporarily reverses the effect of opioid overdose, and there's been a huge, over the last year and a half, rollout of those naloxone kits. Over 17,000 have been distributed, and we've had reported reversal rates of over 1,100, but we know that is grossly underreported, because a lot of people just simply don't report when the kit is used for all kinds of reasons. So we don't have a firm figure on what the true is, but we know it would be much greater than that 1,100, and we're seeing some multiple uses as well. So certainly the rollout of naloxone is one element of that important continuum of services to address the opioid crisis. We also mentioned primary care, so slide 19, really working with primary care networks and physicians and colleges to build addiction mental health competency and capacity within primary care networks, who are recognizing that is where most Albertans go as a first point of contact for services, including for mental health needs, and working with them to establish those mental health services within primary care and within primary care networks specifically. Mentioned work underway in Calgary, also Peace River. We've got some quite exciting work there around working with the primary care network, where that becomes a health home for Albertans in that area, in which those addiction mental health services can be embedded right in there. So relatively excited about those elements. We're recognizing, all these things that we've talked about. I think come from the questions and things that you've signaled in advance of this presentation. Really recognize the importance of that real engagement with community, families, and patients, informing the work we do. And there's all kinds of great examples in which either having families and patient representatives embedded right in the work or consulting directly with them has really resulted in more effective services and services that better meet individual needs. So be that peer support workers, be that within the SCN where there's a patient advisor, and we've also worked with our patient advisory councils when we do policy development, and when we have innovative services that we're wanting to test and pilot and are developing. Really critical that we hear your voice, and we certainly really appreciated that voice thus far in the work that we've done. So really important that we continue on this journey. We continue to need your help in many areas. One is, around that advocacy. We're working on patient-centered care. Really want to continue to hear from you in terms of what does that really mean? What does patient-centered care look like at every opportunity, at every point where we touch the health system? And the linkages to the community as well. Not all communities are the same, and we know that there's unique needs in particular areas. We need to understand that, and that's where the input that you provide is so valuable. And also in terms of advisory, as we develop new services, really critical that we hear from you at the early point in that process to get your input on the key elements that need to be considered on it. So those are some of the areas that we wanted to highlight. I know that might raise all kinds of questions. We'd really be happy to respond to them following this session. We did have a number of questions about the root causes of mental illness and certainly addiction, also depression. And I'm going to turn things over back to Dr. Mitchell to speak a little bit, respond to some of those questions, and then we'll turn things over to Jeff Tagg as well.
Thank you, Barry. So yeah, we had received some very interesting and provocative questions about what the root cause of mental illness is, and about rates, and are rates rising, and why might that be? And this is not something that's a simple answer. I think it would easily deserve, well, its own textbook, but at least its own presentation. But to respond to the questions that were raised, we see, depending on the nature of the mental illness, there are some that are increasing in frequency and some that aren't. So for example, in our population, schizophrenia is actually stable. The rates of schizophrenia in the population, lifetime rates are about 1%. And they've been 1% since the 1950s. Those haven't changed. What we do see increasing are rates of anxiety and depressive illnesses. And those tend to be particularly higher in our younger people, so our children and adolescent age groups. So this can kind of link back to what causes them. Some of our mental illnesses, like bipolar disorder, like schizophrenia, we have a good understanding that they're very heritable. That means that they're largely driven by genetics. There is always the possibility of some impact of environment on the expression of those illnesses. We can usually track them through families, and there's been a lot of work done to try to identify what are the genes or groups of genes, so that we could actually maybe even screen people in advance and treat them earlier. When it comes to things like stress or anxiety or depression, we do see rates increasing over time. While there's a genetic component to those illnesses as well. For example, you're about twice as likely to have depression if you have a family member with depression than you are if you've never had a family member with depression. So that suggests that there is a genetic component to it. What we've seen across populations, whether that be indigenous populations, urban populations, rural populations, males, females, what we've seen is since the 1950s at least, there tends to be higher rates in every subsequent generation of depression and anxiety, as well as suicide. So there have been some concerns as to why that is. One of the reasons is actually that we're identifying people more readily now. So that is a real impact, where generations ago individuals would be less likely to seek help for addictions or mental health concern. They're much more likely, about 3 times as likely to see a physician or a nurse or seek out help through the healthcare system if they have depression or anxiety. One of the other things, though, that we know is that there have been significant changes in society, and one of them, has to do with the nature of our communities. There's been an increasing awareness of the impact of life stress, particularly early life stress, on the development of mental illness. So if you have a significant episode of abuse or neglect or trauma, particularly in the first 2 years of your life, you're much more likely to develop a mental disorder in your adult years. But what tends to reduce the risk is if you have good connections with attachment figures. So if you have people in your environment that you trust and build trusting relationships with early on that persist through your life, that reduces your rates of mental illness. So with the the changes in our communities over time, and people feeling and being less connected, there is an opportunity for people not to have those important relationships. Rates of suicide, as I mentioned, have increased over time. If we look back to the 1950s to now, they're about a quarter higher than they were in the 1950s. But what's much more troubling, actually, is that rates are significantly higher in young people. While the rates in middle-aged adults have increased slightly, where we've seen the biggest uptick is actually in children and youth. And one of the things that we did not talk about isn't trends, but one of the trends that we're seeing is our young people are much more likely to be using addictions mental health services now than they were even 5 years ago. The rates are increasing quite quickly.
And
So
Nick, it's Sheila here. We just have about 5 minutes left in the presentation.
We just need to, this is one of the things that we need to think about strategically, is how do we adapt our services to changing demographics? So how do we, as the rates of presentation change, or how they present in populations, what age groups they present in change, how do we change our services to meet that need? And one of the difficulties is that we tend not to be on top of it. We tend to always be reactive. So we see the issue and then we respond to it. And that's something where, particularly with our long-range planning initiatives and with initiatives where we're partnering with human services and education, we are trying to get upstream and address addictions mental health concerns in youth in school and in early life. So that was all I wanted to say to respond to those questions, but thank you for your attention, and I'm not sure, Sheila.
Thank you very much, Nick and Barry, and I'll hand it back to Jeff Tagg now. Jeff?
Well, I'd like to really sincerely thank our presenters for the incredible amount of information they've given us. I think you can see it now why they're such important resources to our council. And a big thank you to all you who are attending this session. A recorded version of the session will be sent out shortly. Where possible, follow-up in-person discussions can be scheduled with advisory councils or foundations or other groups. The next session will be on continuing care and on June the 28th. And then in the fall, the cancer care and system navigation are scheduled. A reminder that if you've got questions on the presentation today, please email community.engagement@ahs.ca. Please, you'll be receiving a survey shortly, and we're asking you to complete it, and we'll do our very best to make improvements for the next session on June the 28th. So once again, thank you sincerely for your time. You are all now pioneers in a new way of delivering this particular type of information. Thank you.